Welcome to the ASCO Guidelines episode of the ASCO University Weekly Podcast. My name is Josh Lauring, and I am an assistant professor of oncology at the Sidney Kimmel Cancer Center at Johns Hopkins. Today we feature an ASCO guideline, Standards and Guidelines for the Interpretation and Reporting of Sequence Variants in Cancer, published in the Journal of Molecular Pathology in January 2017. The goal of precision oncology is to individualize diagnosis, prognosis, and treatment by identifying and targeting the molecular drivers of each patient's tumor. Clinical-grade laboratory next-generation sequencing tests for tumor tissue have been widely adopted, yet these tests are highly complex and present challenges in both execution and interpretation. Recently, the Association for Molecular Pathology convened a multidisciplinary panel of experts from the College of American Pathologists, American College of Medical Genetics and Genomics, and American Society of Clinical Oncology to standardize the classification, annotation, interpretation, and reporting of sequence variants identified in tumor tissue. The guidelines are based on literature review, empirical data, and professional judgment of the working group members. Genomic variants of interest include mutations, copy number changes, and gene rearrangements. These alterations may be somatic, arising in the tumor, or may be of germline origin. The guideline recommends the use of Human Genome Variation Society nomenclature and unambiguous identification of variants based on genomic coordinates, with details of version numbers for reference genomes, mRNA transcripts, and proteins. Without such details, it can be difficult to verify variants or to compare variants seen on one test with another, for example, a germline variant previously identified in a patient. The variant calling pipeline must be validated, and variant calls should be supported by read depth statistics and variant allele frequencies. This is especially important when tumor sequencing is done in the absence of a paired normal sample, where the allelic frequency can be helpful in assessing the probability that a variant is derived from the germline. This information is also helpful to evaluate tumor clonal heterogeneity. The guideline describes public database resources that may be used to annotate genomic variants, but notes that the laboratory must understand the design and potential limitations of each database. Population-level databases are often used to filter out variants identified in tumor-only sequencing that are relatively frequent in the general population, and which are therefore more likely to be benign germline polymorphisms rather than pathogenic somatic tumor variants. The minor allele frequency cutoff is arbitrary, but the working group recommended 1% in the global population as a reasonable standard and noted that ethnic group-specific allele frequencies may be used as appropriate. Be aware that subclinical disease-causing variants, such as JAK2 V617F mutations, may be present in, quote, healthy, unquote, population databases. Cancer mutation databases, such as the Catalog of Somatic Mutations in Cancer, also contain instances of common benign variants found in germline population databases. A number of in silico tools are available to predict variant impact on protein function. However, the specificity of these tools is moderate. They should be used with caution and should never be the sole factor for variant classification or clinical decision-making. One of the most important aspects of annotation is the interpretation of variants for their clinical impact, for diagnosis, prognosis, therapy, and prevention. 4 levels of evidence are proposed, A through D, which are then organized into 4 tiers. Therapeutic Tier 1 variants have Level A evidence from FDA-approved indications in specific tumor types or professional guidelines, for example, BRAF V600 mutations in melanoma and lung cancer, or Level B evidence for variants shown to be predictive in well-powered clinical studies with expert consensus, such as BRAF V600 mutations in hairy cell leukemia. Tier 2 is a broader class of variants. It includes those with Level C evidence, that is, some evidence of clinical activity in a different tumor type, or which are eligibility variants for a clinical trial, and Level D evidence, which is preclinical only. Examples of Level C variants are hotspot mutations in PIK3CA and ERBB2. Tier 3 variants are of uncertain clinical significance, and Tier 4 variants are those classified as benign or likely benign. A similar classification applies to diagnostic and prognostic annotation of variants. The guidelines suggest that variants be presented in order from Tier 1 to Tier 3, but Tier 4 variants should not be reported. These tiers provide a useful evidence-based framework, but the end user should still interpret these classifications with his or her professional judgment. Clinicians and patients should be aware of the reasonable possibility that a germline pathogenic variant may be identified by tumor sequencing. If normal tissue is sequenced, pathogenic or likely pathogenic germline variants should be reported, with appropriate patient consent, according to ACMG guidelines. If tumor-only sequencing is performed, potentially germline pathogenic variants should not be reported as such, but the annotation should discuss this possibility and the uncertainty. Laboratories should have a strategy to identify potential germline variants in tumor-only studies, using allele frequencies and assessment of tumor cellularity as a first approximation, and should cross-check potential variants against germline databases such as ClinVar, Human Gene Mutation Database, and others. A plan should be in place for referral to genetic counseling and dedicated germline testing, again with appropriate patient consent. The guideline emphasizes both clarity and supporting evidence in reports. The critical information should be presented to the clinician in a readable, direct, and uncluttered fashion. Reports should provide requisite details about technical specifications, such as sensitivity and specificity and genomic coordinates of variants, but these may be best included in a table or appendix at the end of the report. Reports should include pertinent negative findings such as the definitive lack of an EGFR mutation in lung adenocarcinoma, and reports should explicitly describe the types of findings that are and are not reported. Clinical annotations should be evidence-based, and they should take into account the patient's tumor type. But the language should note that a treatment plan cannot be determined solely on the basis of tumor genomic data available to the pathology laboratory, and that many additional clinical factors will impact therapeutic decisions. Reports should be static, but it is anticipated that annotations and clinical impacts of variants may change over time. While the laboratory is not obligated to re-review findings based on new scientific knowledge, laboratories should anticipate requests to revisit old data and should develop policies and procedures to handle such requests. Thank you for listening to this week's episode of the ASCO University Weekly Podcast. For more information, be sure to check out ASCO University's quarterly e-learning series on ASCO guidelines by visiting university.asco.org.
The purpose of this podcast is to educate and to inform. This is not a substitute for professional medical care and is not intended for use in the diagnosis or treatment of individual conditions. Guests on this podcast express their own opinions, experience, and conclusions. The mention of any product, service, organization, activity, or therapy should not be construed as an ASCO endorsement.